a resident of Mumbai who belongs to lower middle class, presented with chief complaints of progressive deformity of trunk since childhood. History of presenting illness. Patient had a history of lateral bending of vertebral column since childhood. Started at around 8 years of age, which is gradually progressive in nature and associated with stiffness of trunk. Uh, she has a history of difficulty in breathing, which started 4 months back. Uh, 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 Initially, it was only an exertion, now progressed to grade 3, and no history of orthopnea and PND, no history of numbness or weakness of limbs, no history of fever, cough, or sputum production, no history of chest pain, palpitations, and syncope and swelling of legs, and no history of difficulty in neck movement. Then past history, there is no history of congenital deformities and no history of similar complaints in the past. She is not a known case of diabetes, bronchial asthma, tuberculosis, and seizure, and no history of past surgeries, and no history of any blood transfusions or any ICU admission, no history of any COVID. Then personal history, she consumes mixed diet, normal sleep, and she has normal appetite, regular bowel and bladder habits. Natal and postnatal history, she delivered a term by normal vaginal delivery, birth weight 2.5 kilos, no history of any ICU admission after delivery, and immunization is up to date and milestones were normal. Then family history, no history of any similar complaints in the family, no history of any congenital anomalies or any chronic illnesses. There is no history of any allergy. And then coming to general physical examination, the patient is conscious, cooperative, oriented to time, place, and person. And then no pallor, icterus, cyanosis, clubbing, lymphadenopathy, or pedal edema. Weight is 42 kilos, height is around 150 centimeters, and BMI of 17.8. Vitals, pulse 98 beats per minute, regular in rhythm, normal in volume, and character, no radio-radial, radio-femoral delay. Blood pressure is 110 by 70 millimeters of mercury in right upper limb in sitting position. Respiratory rate 16 per minute, regular time. Saturation is 98 percentage at the room air. Temperature is patient is febrile. Then coming to head to toe examination, there is no craniofacial abnormality. Right shoulder is lower than the left shoulder, and the spine convexity is towards the posterior and to the left side. Then abdomen and external genital are normal, and extremities are normal. Then coming to airway examination, she has mouth opening of 3 fingers, around 6 centimeters, and Malampati class 2. Dentition, there is no loose teeth and dentures. Neck movement, flexion and extension are adequate, and the lateral movements are normal. Thyromental distance of 6.5 centimeters. Then coming to systemic examination, RS respiratory system on inspection, trachea is midline, shape of the chest is symmetrical, right shoulder.
Go ahead. I'll find out all the points in the last, whatever missing or not correctly reported.
Yes, sir. On palpation, all inspectory findings are confirmed.
You are committing chest wall symmetrical, isn't it? Chest wall symmetrical is your commitment. Is it right?
No, sir. Sorry, sir. Chest wall is not symmetrical.
So
no,
don't go by the routine method of description, because
okay,
so
sir.
that is right.
Yes,
Chest wall could not be symmetrical in this case.
Yes, sir. Yes, sir. On palpation, all inspectory findings are confirmed. Trachea is in midline. No warmth and tenderness is noted. Chest expansion is around 3 centimeters and IP diameter is around 15 centimeters. On percussion, resonant note noted heard in all areas: supraclavicular, infraclavicular, mammary, axillary, and infraaxillary, supraclavicular, infraclavicular, and infrasclavicular areas. Auscultation, normal vesicular breath sounds heard in all areas. Coming to cardiovascular system, on inspection, GVP is normal. Apical impulse is not visible. No precordial bulge. No visible pulsations. Scars and sinuses are seen. On palpation, apical impulse felt at left fifth intercostal space, half inch medial to mid clavicular line. No parasternal heave or thrill. Auscultation, aortic, pulmonary, tricuspid mitral area. Heart sounds are heard and no murmurs. CNS examination, higher mental functions are normal, cranial nerves are normal, reflexes are normal, there normal tone. There is no signs of meningeal irritation. And coming to motor, upper limb and lower limb motor power is on both right and left limbs is 4/5, 4/5. Then coming to abdominal abdominal system, inspection normal shape. Abdomen is normal in shape, not distended. All quadrants move equally with respiration. Umbilicus is normal and in midline. No visible pulsations or peristalsis. Palpation, no warmth and no tenderness, and there is no organomegaly. Percussion resonant noted all over the abdomen, and auscultation normal bowel sounds are heard, no bruit. In spine examination, right shoulder is lower than the left shoulder. Then right scapula is lower than the left scapula. Then spine convexity is towards posterior and then towards the left. Then Cobb's angle is around 40 degrees. Then that's all, sir. Coming to summary.
Okay, so summarize. Problem.
Here is a 17-year-old girl presented with complaints of gradually progressive deformity of trunk since childhood, with progressive difficulty in breathing for 4 months, with convex with spine deformity with convexity posteriorly and to the left, from in the lower thoracic and lumbar level, with Cobb's angle of more than 40 degrees.
Probably, what is your diagnosis?
Probably adolescent idiopathic scoliosis involving lower thoracic and lumbar level.
Kyphoscoliosis or just scoliosis?
Kyphoscoliosis, sir.
Okay, so adult ASI, kyphoscoliosis, lower lumbar and thoracic, lower thoracic and lumbar region. Okay. Have you missed anything important in the history? Can anyone say whether he has missed an important question, or if the patient has not complained, you should probe and find out that he missed anything? He straight away went to say that patient is having breathing difficulty for the last 4 months. Any other difficulty he should have asked?
Walking.
Huh?
Gait.
Gait, walking. When a patient has got a shoulder elevation to this level, one shoulder is down, one shoulder is up. So patient is likely to have a gait imbalance. So sometimes they may not also have, but you should never forget to ask about any change in the gait. Because patients, when they chronically walk on one side, lifting the other limb, they may not remember that, because they are used to that from the age of 8 to 17. If he has been walking with a limp on one side, he will not complain. He will only say, my back is looking abnormal. So unless you ask about the gait, patient will not sometimes reveal that also. So in your examination also, you should ask the patient to walk and see whether their stepping is a little abnormal on one side because of this change in gait. And examination of the abdomen, you said all quadrants are equal. So when the thorax is tilted to one side, will you find the distance between the lower rib on the right side and the anterosuperior leg spine same, or it will be narrow? When the right shoulder is down, narrow. The left shoulder is up, then you cannot commit that the abdomen is looking normal on all sides. Okay, these two. And you started off saying that chest wall expansion is symmetrical. That is also a very important thing. So all these things show that you have taken an imaginary case, not a real case. Okay, that is the reason why this mistakes have happened. So don't forget about the gait. Don't forget about the unequal chest size and the expansion, and the unequal size of the abdomen between the affected side and the normal side, okay, or the compensatory side, like that. So these are the mistakes that you have to correct in your theory and presentation. Now the common questions that they will ask you is, supposing this patient, does she require surgery?
Sir, she has a Cobb's angle of around 40 degrees.
40 degrees.
So 30 to 40 degrees, we should consider for surgery, sir.
Surgery 40 and above, not 30 to 40. 30
Yes.
to 40 also can be
Okay.
sometimes conservatively managed. What is the conservative management? Did
Yes,
you
sir.
ask about any treatment of conservative treatment for this child at the younger age? As they notice it from the age of 8, this problem could have been averted if they had done some conservative treatment for this patient. And that history also is very important for you. You should have asked that treatment history. What is the treatment, conservative treatment that can be tried when the child is growing? If it is detected at the age of 8 or 10, before she reaches this adolescent age of 17, what is the conservative management that is done?
Braces.
They apply braces, chest braces to straighten
Yes,
the
sir.
spine. They put a plaster cast
Okay, sir.
around the whole chest and then ask them to wear it all the time for at least 6 months, so that
Okay, sir.
the spine, as it grows, doesn't have that tendency to bend. It will go straight because the whole body is encased inside a plaster cast. Okay, that's called chest braces are there,
Okay, sir.
which can be tried. So that history also you should see, and sometimes that may fail. That only they becomes more aggressive, and the Cobb's angle becomes more and more. So the other common question they
Okay,
can
sir.
ask you is, how do you calculate the Cobb's angle?
Uh, Sir, for calculating the Cobb's angle, the uppermost vertebra from where the curvature starts and the lowermost vertebra from where till the curvature ends should be noted. Then two parallel lines should be drawn from the upper end of the upper vertebra and then lower end of the lower vertebra. And then one perpendicular lines should be drawn from the both these lines. The angle and the intersecting angle of these perpendicular lines, the angle is the Cobb's angle.
So do you all agree with this answer? Vinita, do you agree with this answer? If you just say vertebra,
Direct
I will draw a line. What is the thing first you require? What investigation you have
standing
to do to find
X-ray,
the
X-ray.
Cobb's angle? You need to make an X-ray of
X-ray.
the thoracolumbar
Yes, sir.
spine in lateral view.
Okay, sir.
Okay, that is the first answer.
Okay.
Without that, just don't expect the examiner to imagine all that. Okay, sir, I will take an
Okay.
X-ray of the thoracolumbar spine lateral view and then draw a straight line from the uppermost vertebra where the curvature starts, the lateral curvature starts, from the body of the vertebra. Okay, you must specifically say from which
Okay, sir.
part of the vertebra you are to. You can draw a line from the transverse process. You can draw a line from the spinous process also, but you must say that it is
Okay,
a
sir.
line drawn from the uppermost the
Body of
vertebra
the
where the curvature starts on the body of the vertebra, and the one from the lower part to the lowermost part of the vertebra from the again the body you must draw, and these two lines will meet each other and make an angle. That itself is enough to find out
okay, sir.
the angle. Otherwise, you can draw, as you said, a perpendicular line which cuts each other and then measure also. That is another method of calculating. So please remember that you have to say you need an X-ray of the
Yes, sir.
thoracolumbar spine in the lateral view.
Thoracolumbar spine.
Then only you can
Yes,
calculate
sir.
this. Okay. So without saying
Okay,
that,
sir. Okay.
to start with that, then it will be easy for you to make the examiner get very impressed, instead of saying just I will draw the line and then it will cut and make that right. So
Okay, sir.
the patient is also very symptomatic that she is now becoming breathless. She is not able to carry out her work, and there is a curvature also. Growing girl, 17 years, likely to get married and all that. So they want cosmetic reasons also. They want the whole thing to be corrected. So she is posted for
Yes, sir.
correction. What is the corrective surgery that can be done for this?
Uh,
What is the
uh,
operative procedure that is done?
Spinal fusion with rod placement, sir.
Excellent, very good. So it's called Harrington rod insertion and spinal fusion to straighten the curved spine. Excellent, very good. So that is
Yes,
the
sir.
procedure that is going to
Okay,
be done. Have you ever done a case like this in your training period during
Mm.
these 3 years?
No, sir.
You have
No,
not
sir.
seen. Okay,
No.
that's very unfortunate. Okay, but that is not an excuse in the exam that you cannot say I have not seen, sir, so I won't answer. You think it will not be accepted. So you have to know the basic principles at least. So how do you anesthetize? Have you done
Okay,
any
sir.
other spine surgeries like discectomy or laminectomy?
Yes, sir. Yes, sir.
So it is almost similar to that only, except that you are not seeing this particular procedure. It is another type of spine surgery. Okay, so if you have
Okay.
seen
Yes, sir.
discectomy or laminectomy, then this should not be a problem for you, except for some few changes compared to the other surgeries. Okay, so
Yes,
now
sir.
that you know that you have done a discectomy or laminectomy, a spine procedure, tell me how will you anesthetize a patient for a spine surgery? Let us for a moment forget about the scoliosis correction. Let us go for common spine surgery anesthesia.
Sir, for spine surgery, my plan of anesthesia will be general anesthesia with endotracheal intubation with
Very
controlled
good.
mechanical ventilation, sir.
Excellent.
Sir, as spine surgery will be done in the prone position, I will put a flexometallic tube, sir.
Excellent. Very good.
Uh,
But what is the method
so,
of induction? Can you put the patient in prone and induce and intubate, or
no, sir.
what is the
No,
way
sir.
you do it? Tell me the
In
practical method of management.
Okay, sir.
Right from starting
Initially,
the
the
patient.
okay, sir. Yeah, patient will be taken to the OT. Patient will be all monitors will be attached. Then patient will be pre-medicated. Pre-medication given with injection glycopyrrolate, injection midazolam, injection fentanyl. Then a patient is pre-oxygenated with 100% O2 for 3 minutes. Then patient is induced with I plan to induce with injection propofol, sir.
Okay.
Injection propofol. Then muscle relaxants are given. Then propofol. Then I am planning to use non-depolarizing muscle relaxant atracurium. I will use injection atracurium. Then for intubation, I will use I will do the orotracheal intubation with flexometallic tube, sir. Then
But all
tube
these things you will do
position
in
will
the
be
OT table.
no, sir. I will do all these things on the trolley.
That is the first and
Trolley.
foremost point that you have to say. Patient has to be induced in
Okay,
the
sir.
stretcher trolley and then transferred onto
Trolley.
the operating table. Okay, that
Yes,
you
sir.
cannot
Okay.
expect the examiner to understand that. Oh, you will be Sanjeev Raju will be inducing the patient only in the stretcher trolley and then transfer the patient to operating table. Okay,
Okay,
so
sir.
by
Got
saying
it.
these small
Okay, sir.
practical points, you will impress the examiner more that you have done the case and you have observed the points and you will remember the points. What
Yes,
are the
sir.
difficulties in
Yes, sir.
inducing a patient in a stretcher trolley?
Sir, in stretcher, first of all, stretcher should be stable. Some stretchers wheels
Excellent.
don't have locks. Wheels don't have locks.
They may
So some
move.
person should be holding the some
So
person
they are
should be
mobile.
holding
The
the
stretcher trolley
stretcher.
is not
Yes, sir.
stable like your OT table. Okay, so you have
Yes,
to
sir.
make sure that the trolley is in a fixed position, either by using the
Yes,
locks
sir.
for the wheel or asking somebody to give a counter push from the foot end of the patient while you do
Yes, sir.
the laryngoscopy and intubation. And will you place all the monitors, ECG monitors also in the trolley itself in the supine position before turning the patient? What is the disadvantage in putting all the 5 leads in the chest and then turning the patient?
Sir, there is a chance of dislodgement, misplacement,
Not
and
only
then
dislodgement. When you
another risk
place them, the
another
support.
risk is bedded in wash.
The electrodes can be compressing the chest, okay, or
Yes, sir.
will be coming off. So it is better
Yes,
that
sir.
you apply the electrodes in such a way that they don't come in the posterior, in the anterior aspect of chest. Okay, so it is better to
Oh,
apply
yes,
them
sir.
on the posterior aspect after you turn
Posterior
the
aspect.
patient. Okay, so being a young
Okay, sir.
lady, it is enough that if you have a pulse oximeter and a NIBP cuff to monitor the patient, and then after
Yes.
positioning in the operating table with the support, then you can place all the electrodes in the arm and the upper part of the back instead of putting it in the chest straight away. This one practical tip that you can remember, right? Okay, so
Okay, sir.
flexometallic tube you will use. So how, what is the name of the support that is used for spine surgery?
Wilson frame.
Wilson's frame, very good. So what are the precautions you have to take when you turn the position to prone position?
Sir, first thing is you have to stabilize the head, sir, while
Hmm.
turning.
Hmm.
C-spine stabilization should one person should be there to hold neck, and ET tube dislodgement can also be there. So
Okay.
then um, uh, um, other thing, one people enough number of people should be there for turning to
Very
prevent
good.
injury to the legs and limbs, lower limbs.
Okay. Hmm.
Sometimes there is a risk of IV cannula dislodgement while
Very good. Hmm.
turning the. Then if patient is already catheterized, we should take care to prevent the removal of Foley's catheterization.
Very
Then
good.
bolsters, we should uh, bolster should be placed such that the abdomen should be freely hanging.
Very good.
Then pad, bony prominences should be properly placed.
Hmm.
Then uh, face face should be free with the use of by using um, soft gel cushion pads
Very
to
good.
prevent injury to the eye and bony prominences.
Excellent.
We can also place mirror to observe whether there is any compression of ET tube or eyes or nose,
Very good.
or
What about the upper limb
other
position?
thing. Upper limb position, mm, limb should not be over abducted. They should be flexed
Hyperextended.
at the.
You must use
Yes,
the
sir.
word
They should
hyperextended.
be. Okay, sir. They should be
Okay.
flexed at the
Similarly,
elbow, and
which
then
other pressure point is important? You said bony
knees.
prominences. Any soft tissue or any structure which should not be compressed?
In females, sir, breast, and in males, genitalia,
Hmm. Any other
and then
vascular structure which should
knees.
not be compressed?
Uh,
A prone
uh,
position.
fem-
Iota.
groin, groin,
Groin area, femoral vessels.
groin area.
That is a very,
Okay,
very
sir.
important thing. Sometimes, abnormally placed patients can have compression of the both femoral artery and vein. That may
Femoral.
cause
Yes, sir.
not only ischemia to the lower limb, but also prevent the venous return and cause a decrease in the cardiac output also. So that
Cardiac
area,
output. Okay,
groin
sir.
area should be correctly placed without compression on the femoral vessels, apart from the genitalia in
Okay.
male as well as in the breast in the female. Okay, so these are very important,
Yes, sir.
and especially eye padding
Okay,
is
sir.
also very important. Right. Now coming to
Yes, sir.
after the positioning challenge, what is the intraoperative requirements for this particular surgery, for this scoliosis correction? Of course, in your other spine surgeries also, these points are somewhat applicable to them also.
Okay,
But
sir.
in scoliosis
Sir,
surgery, what are all the challenges that you will face apart from this positioning challenge?
uh, sir, we optimal hypotensive anesthesia should be maintained, sir, to prevent excessive blood loss.
Very
Then
good.
intraoperative neuro monitoring should be done to
Very good.
check whether
Yes.
whether there is an intraoperative neuro
Very good.
loss.
So what are the neuro
Uh,
monitorings that are done?
Sir, there are two types. One is somatosensory evoked potential, then
Hmm.
motor evoked potential, and then there is another test called wake up test, Tegner's wake up test.
Okay.
somatosensory wake-up tests. In this, they check the integrity of the posterior columns. In
Very
this,
good.
the peripheral stimulus is given, and then response is noted on the at the level of vertebral column or either at the cerebral cortex. So here in the somatosensory evoked potential, we check the latency and amplitude. Latency is a time interval between stimulus and the response, and the amplitude is the voltage of the response. So if and then
now if the surgeon says that he wants to test the neuro integrity intraoperatively, in what way it is going to affect your anesthetic technique?
Sir, if the intraoperative neuro monitoring, if sir, first of all, the patient should be counseled during if we are planning for wake-up test.
Motor evoked potential, do you have to counsel the patient, or it is only
No need.
for wake-up
Sorry,
test?
sir, no need. Only for wake-up test. Only for wake-up test.
So be careful in that answer. Wake-up test only requires proper counseling before you start the procedure. But for somatosensory and motor evoked potentials, you don't require any counseling because they are all done intraoperatively without waking up the patient itself. So that is the difference. But what way you have to modify your anesthetic technique to facilitate the conduct of this neuromonitoring?
Sir, for this neuromonitoring, short-acting agents should be used so that they can be
in other
stopped
words, in your
prior
routine
to.
method of anesthesia, how will the neuromonitoring get affected? Which agents will suppress or prevent the stimulation and the getting the results of neuromonitoring?
Inhalational agents, they will suppress the neuromonitoring, sir.
Very good.
So
then any other agent? Any other agent which you use normally for your anesthesia purpose? Only inhalation agents or any other agents also will affect?
Neuromuscular blocking agents.
When you want motor evoked potentials and you paralyze and control the ventilation completely, which you do normally for any major case, can you get the motor response?
No, sir, no.
No. So these modifications should be avoid inhalation agents, totally avoid neuromuscular blocking agents. That is the challenge in neuromonitoring for this particular type of scoliotic corrective surgery. So how are you going to keep the patient unconscious and at the same time allow the surgeon to perform the neuromonitoring? If you know that answer, the procedure is over.
Yes, sir. Sir, I will go for IV intravenous anesthesia.
Very good. What are the drugs you can use for that?
Sir, we can propofol, infusion of propofol. Then it can be dexmedetomidine can also be used.
Cannot be used. Why?
Can be used, sir. They can be used.
Can be used.
Can be
used.
Yes, sir. Dexmedetomidine can be used. Then opioid infusion can be used. Like fentanyl.
Can you use midazolam?
Midazolam will decrease the benzodiazepines will decrease the amplitude of
amplitude and
somatosensory.
So there is a
and increase the latency.
Ketamine can you use?
Yes, sir. Ketamine increases the stimulates, sir. It exaggerates the response.
So propofol and dexmedetomidine are the two drugs which are ideal for producing a total intravenous anesthesia without the need for any inhalation agents or neuromuscular blocking agents, and facilitate the stimulation and neuromonitoring can be easily done. That is the main important thing. What is the second challenge in this type of cases? Supposing they want to do the correction of the lower thoracic and the lumbar vertebra in one sitting, they want to put a long rod and fix all the spines and do a extensive procedure for 6 to 8 hours. What are the other challenges that you will face because of that long surgery and an extensive surgery?
One is blood loss,
Blood loss,
or major
very
blood
good.
loss, massive
So
blood
how
loss.
are you going to manage the blood loss? What are the techniques for managing the
Sir,
blood?
sir, for during for intraoperatively for managing the blood loss, first thing is we can go for hypotensive anesthesia.
What is the risk in
Uh,
practicing hypotensive anesthesia for this particular surgery, where they are going to distract
Sir,
the bone and stretch the spinal cord? What is the risk in hypotensive anesthesia?
there is a risk of decrease in perfusion to spine.
Excellent.
So that will
Spinal
aggravate
cord,
the
not spine,
neuro
spinal cord.
injury. Sorry,
Okay.
sir, spinal
So
cord.
ischemic injury can
That will
happen.
aggravate that injury.
Okay.
Yes,
So
sir.
what are the so if surgeon says no spinal hypotensive anesthesia, by they will just keep normotension because I want the spinal cord to be well perfused. If that is the request from the surgeon, how are you going to avoid intraoperative blood loss? Always for this question, you start from the preoperative preparation. If this question is asked in examination, how are you going to manage the blood loss in scoliosis surgery? You must always say the preparation starts from the preoperative phase. So what are the preoperative phase preparations you can do for the intraoperative management of blood loss?
Okay, sir. Sir, preoperatively during we'll do the during evaluation we'll check the in CBC we'll check the hemoglobin level.
Very good.
If hemoglobin is low, we'll correct by giving IV iron sucrose or any other hematinics. Then if hemoglobin is good more than 11, then we can go for autologous blood transfusion. We
what
can
is the
collect
normal
the patients.
hemoglobin for a female patient? If 11 is enough?
11 to
normal
13.
Hemoglobin for a female patient and a male patient.
Sir, male patient 14 to 16.
Female 12 to 13. 12. So 11 means you
12.
cannot do any collection from the patient. Okay, patient should have at least minimum 12 grams of hemoglobin for doing what is called autologous donation. They can donate their own blood. Supposing patient's hemoglobin is acceptable, 13 grams, she is looking well nourished. Then how are you going to collect the blood? What interval you can collect? How many units?
Sir, pre-operate. Sir, collection should start before 4 weeks, sir.
Very
we can
good.
collect 2 to 3 bags of blood and interval of 4 to 5 days.
1 week. Okay, very good. So 1 week.
1 week. And
do you do any supplementation during this gap?
Yes, sir. Iron supplement should be given, or erythropoietin can be given.
Very good. So this is the autologous donation. What is the next method? Supposing patient is
next
not.
Method. Sorry, sir. Question.
Second method, done on the day of surgery.
Yes, sir. 3 to 4 hours prior to surgery, we can collect the blood. So,
what is
and
the
then
name
we can
for
store
that
it.
procedure? It is called isovolemic.
I forgot the name.
Yes. It's called isovolemic. That is, you maintain the volume of the patient, blood volume. Yes. Isovolemic donation on the day of surgery. Okay. So you can collect 300 to 500 ml of blood on the day of surgery and replace it with
fluids, IV fluid, crystalloids, or colloids.
Not isovolemic, it is normovolemic on the table donation. Okay, so that can be done.
Sir.
by transfusing 2 pints of crystalloids for every 1 pint of blood that is taken. And then the third method is, which is done intraoperatively.
Intraoperative cell salvage, sir.
Cell salvage. Okay, so these are the 3 common things that are expected from you. One is autologous donation done 3 to 4 weeks prior to surgery. Second is normovolemic donation on the day of surgery. Third is intraoperative blood cell salvage, which can be collected and then retransfused. What are the other methods of preventing apart from cell salvage intraoperatively? Any pharmacological method you can try? Not about lowering the blood pressure, but vasoconstriction can you produce the operative site selectively? Infiltration with vasoconstrictor, dilute epinephrine. Okay, you can put adrenaline saline injection into the tissues, or you can even use tumescent local anesthesia into the entire skin and subcutaneous tissue where you are going to operate, and that will produce an excellent local vasoconstriction and produce a bloodless field and prevent the blood which is mainly oozing from the muscle and subcutaneous tissues and all these soft tissue areas. Okay, so that is the fourth method. 3 methods already we have told: autologous collection, normovolemic hemodilution, third is the cell salvage, and fourth is infiltration with vasoconstrictors, dilute epinephrine or tumescent local anesthesia in the site of surgery. Don't mention about hypotensive anesthesia, because here the spinal cord is going to be stretched, so there is a possibility that if the mean arterial pressure drops too much, there is a possibility of spinal cord ischemia. So it is not preferred by many surgeons. Okay, so these are all the points that are required. What about analgesia? Because this is a quite painful procedure. Patient a lot of bones being chipped off and screws fixed, and then the stretching, all these things are there. So what is the analgesia you will provide for the surgery?
Sir, intraoperatively, I will go for multimodal analgesia with paracetamol and then NSAIDs, diclofenac, and then intrathecal infiltration, intrathecal morphine can be given, sir, by the surgeon.
Very good.
Then epidural catheter placement also can be done.
Can be done, yes. So if the surgeon agrees, he can put in an epidural catheter himself at the end of the surgery for closure. But it should be very, very strict asepsis should be provided. Otherwise, there's a chance that it can get infected. So many surgeons may not like to use that. But it is one of the methods that is done in Western countries, because they are quite confident about their asepsis. And you can put an elastomeric pump and then produce any other less invasive or less chances of infection which you can do from the beginning itself before you start the procedure. It is commonly used for many centers where spine surgeries are done. Erector spinae plane block. Because you are going to do the surgery in the midline. So erector spinae plane block given prior to the starting of surgery produces very good analgesia both intraoperatively and for prolonged postoperative analgesia is also there. So bilateral erector spinae plane block using ultrasound is the current technique or a recommended technique for regional anesthesia for spine surgeries, whether it is scoliosis or whether it is discectomy, laminectomy, all these things. Any spine surgery, you can say in the exam that bilateral erector spinae plane block under ultrasound guidance is the current technique of regional anesthesia. Apart from your other methods of paracetamol, diclofenac, and all these things. Because many surgeons don't prefer to put an epidural catheter, but that is also a good option. Okay. And intrapleural analgesia also have been tried, because you are doing the thoracolumbar area, you can put an intrapleural catheter and infiltrate or give infusion of local anesthetic through that also. Okay, so these are the
Okay.
common things that are asked in the examination. We just see a presentation that
Okay, sir.